Good afternoon, everyone. I'm giving you a brief introduction of Robert Twycross, and these are the 5 lines I got here. Dr. Robert Twycross is presently working as an emeritus clinical reader in palliative medicine, Oxford University, the director and editor-in-chief of PalliativeDrugs.com Limited, Nottingham, UK. He has received the Lifetime Achievement Award, American Academy of Hospice and Palliative Medicine, and Lifetime Achievement Award, Indian Association of Palliative Care. He has written nearly 300 articles, chapters, and editorials, and is the author of several books. I think that is too short of introduction of Robert Twycross, because he was my teacher, and probably he taught all the first generation palliative care physicians in India. So he has an overwhelming presence in the palliative care education scene. So I think we are all eagerly waiting to hear what he has got to say. So Dr. Robert, please.
Thank you very much for those words of welcome. It's a great pleasure and privilege to be here. It's always a privilege to be asked to speak anywhere, but it's a particular privilege when you're asked to speak abroad. And for me, India is abroad. So it's just wonderful to come back after a gap of 4 years, and it's so encouraging to hear about the progress which you're making and the challenges, because I think the challenges are going to be even greater in the next 18 years than in the last 18 years since we began the association in Varanasi. Now, I've been given 30 minutes, and that's half an hour, and that means half an hour for half a lecture. So what I've done to compress it down, I've cut out every alternative slide, and I'm leaving it to your imagination and creativity to fill in the gaps. And there'll be a prize, of course, the person who supplies me with the full lecture. But I'm working on the basis that many of you, if not all of you, are involved in palliative care. So I don't have to give the ABC. I can start further down the line. But beware. Now, I'm not going to read all the slides, because you can read them faster than I can speak them. But this is an important message. What I say to you this afternoon may be totally irrelevant. It may have no practical application for you. And if that's the case, I apologize in advance. Now, this is my thought for the day. If you remember nothing else, remember this. The anger in compassion is a catalyst for change. Now, I know all of you who are involved in palliative care are compassionate. Some of you, you've been demoted by your institutions because palliative care doesn't bring in the big bucks like chemotherapy. So they've reduced your salary. You've given up a lot for palliative care. If you haven't had your salary reduced, maybe you've given up private practice. I know you're compassionate people who have been moved by the suffering of people at the end of life. But I want you to be angry people as well, because the challenges are so great, and without the anger in compassion, it'll take 200 years to get to where you want to in this great country of India. Now, I'm not going to dwell on definition. I don't have a book of abstracts in my pack. Maybe it's all electronic. But if you look at the electronic version, you'll see that I mentioned a couple of definitions, one of them the WHO one, which we saw twice this morning. I'm not dwelling on that. You have a fairly good idea of what palliative care is. I did ask someone on the MD working group, what's your definition for the MD program? And I was told that they hadn't got one as yet. But we know that palliative care is something to do with the end of life, with progressive disease, with suffering and the relief of suffering. And I'm going to leave it like that. You tell me next year what definition you're going to use for your MD program, and therefore cascading down to the other programs, some of which we've heard about and have been very impressive presentations. Of course, palliative care is not what we used to call the waste paper basket option. It's not a self-contained compartment at the end of life. It does interact with oncology or whatever. So palliative care is there as a crucial part of a cancer control program. Now, I thought Professor Biasco's presentation was great. You know those 3 wheels, we call them cog wheels, you must have together the pre-graduate training in your medical college, in your nursing college, your nursing school. You've got to have the general training in palliative care, post-registration, and then you've got to have the specialist. And what Professor Biasco said was they have to be there all together, going side by side, integrated. If you try and do one without the other, the whole thing will get imbalanced. And that's perhaps one of the most important messages from this conference. And it's one of the biggest challenges for you, because what is it? 200 medical colleges in India, something like that. And how many of those medical colleges have any palliative care in their curriculum? 5. Okay, 5 out of 200. Well, I can't say it's a disgrace, but it's a crying shame. You know, who's going to head up? Who's going to visit the remaining 195 medical colleges and talk to the directors and principals and say, look, how can we help you get at least a day or half a day of palliative care into the curriculum? So Professor Biasco's interlocking cogwheels, take that away and make that the goal for the next 18 years, moving things forward in gear. Okay, now, I said in my abstract that I wasn't going to give a coherent lecture. I was being just what I am, an old man, an elder statesman, and that gives me the privilege of hopping around here and there, throwing out a few thoughts which may or may not be relevant to you. But you know, and someone said this morning, communication is the key to good palliative care. And didn't someone say you can't but communicate? If 2 people meet, they communicate. Even if they don't look at each other, you communicate. And communication is the A and the Z for the Americans, the A and the Z of palliative care. And that's got to be upfront in our teaching. Let's hope your 200 medical colleges do, in fact, have courses in communication skills, because you can latch onto that and build on that and repeat the basic communication skills with a special emphasis on end-of-life care. Now, this quote on the slide is from a doctor in New York who died in 2000. And during his terminal illness of cancer of the esophagus, he talked to groups like this, you know, to medical students, to doctors around the New York greater area. And one of the things he said was, let patients do the talking, learn to listen. Okay, so that's crucial in our training programs, communication skills. Okay, you've only got 15 minutes, you've got a busy clinic. So, how are you going to give the patient permission to talk? Well, there are 2 suggestions on this slide. What troubles you most? Giving the patient permission to talk, not assuming that it's this or that. Unless you give them permission to talk, you won't be able to listen to them, because patients are hesitant to say things without permission. Give the patient permission to talk. And those questions there are 2 ways of opening up the conversation. Okay, now I added this slide this morning. Attitude. We all know the attitude for palliative care. It's compassion. Cicely Saunders, who's already been referred to, said, about the patient. You matter because you're you. You matter to the last moment of your life. And we'll do all we can, not only to help you die peacefully, but to live until you die. That's the attitude. That's the attitude. And this is part of the attitude. Minimize formality. And I wrote this slide originally when I was describing what I do in my outpatient clinic, or did do. I retired over 10 years ago. I have a presentation called the Palliative Care Consultation, and this is what I call setting the scene. Minimize formality. We want to have horizontal human-to-human relationships. We've got to get away from the vertical professional-client relationship. You know as well as I do that there's power in the professional. Whatever the profession, he or she has knowledge which the client wants. And the professional automatically has this hierarchical power relationship. We've got to get rid of that as far as possible in palliative care. We want horizontal, human to human. You are my brother, you are my sister, and that's got to be our attitude to the patients, however poor they are, whatever caste they are, whatever they look like. They are brothers and sisters to me. I don't care what your religion is, that is a basic attitude which is necessary in palliative care. So minimize formality and maximize did I get it wrong? Anyway, say it with me. Minimize formality, maximize humanity. Couldn't hear you. Come on. Minimize formality, maximize humanity. Hooray! Good. Now, here we are in clinic. Is this how you run your clinic? Here you are, sitting like a government minister, with your big table in front of you. And somewhere down there is the patient, poor little worm. I'll make him feel small. I'm a government minister. But you see, that's what some doctors do. Most doctors do. In your clinic, do you have a chair behind a table with that worm of a patient down there on the floor? When you get back on Monday, make sure you rearrange your clinic. There's no place for a table between you and the patient in palliative care. You're meeting a brother, you're meeting a sister. If you put a table between you and the patient, you are not meeting a brother or a sister. You're playing power games. And power games have to go in palliative care. And this must be part of our teaching. Okay, well, I survived that. I hope you did. Okay, now I haven't got time to tell you this, so I will. But there's a young child, 7-year-old girl, who came home from school and she's very excited. And there was Mummy over there cooking the meal or getting the meal ready for the family. And the girl comes in and she says, Mummy, I've got something to tell you. And the mum goes on working hard, chopping up the carrots or whatever you cut in this country. And the girl starts talking, and the mummy goes on looking down, and the child says, Mummy, you're not listening. And Mummy says, oh, I am. The child replies, but you're not listening with your eyes. We have to make eye-to-eye contact. Maybe not all the time, but we have to make eye-to-eye contact a day. So there you have it. Uncontrolled with slow-release SR, slow-release morphine, 12 grams in 24 hours. But when it is active total care, addressing the psychological, social, and spiritual issues, the pain, A, became relievable, and B, it was microscopic dose by comparison. Communication was the key. Now, this is an extreme example, but throughout my career in palliative care, I've seen this sort of thing time and time and time again. This sort of case is gold for you as teachers. Make sure you have one or two from your own experience and use them to teach people the importance of active total care. Okay, you've also got, I'm thinking, you know, I used to teach medical students, and I love teaching medical students. They're so interactive, at least they are in Oxford. Here we have it. Guys, look, Palliative care, there's nothing soft about it. It's a form of emergency medicine. Are you teaching that to people? Palliative care is a form of emergency medicine. Now, it's not that. You know, if you're dying of cancer and it's obvious you're dying of cancer and someone hijacks you, kidnaps you and puts you in an intensive care unit and puts in all sorts of tubes and all sorts of drugs and charges you lakh after lakh after lakh of rupees, that's almost a contravention of the International Convention on Human Rights. It's almost enough to have you charged and taken to The Hague to the International Court. But that's what's happening, and you know it's happening. You know that the rich people in India are being ripped off in the big private hospitals. You've got to get the rich people on your side. You've got to stop this, because this is torture. Okay? That's not the sort of emergency medicine I'm talking about. I'm talking about speed. These patients don't have months and months, usually don't have months and months for you to make a change in the dose this week, next week, week after. You've got to move with speed. So, here's a patient from another country, from Africa, in fact, South Africa, and I was doing a ward round there some years ago, and he obviously had advanced inoperable cancer. We knew, or they knew, he had pain, but nothing was prescribed. There he was. So I say to him, how long have you had the pain? Oh, 2 to 3 months. And what about the nights? I don't sleep well because of the pain. How long is it since you slept well at night? About 3 months. If anyone says, I haven't slept well for 3 months, that is a medical emergency. Palliative care is a form of medical emergency, or emergency medicine, whichever way you should be around. So this sense of urgency is very important. You can't say, I'll see you in 48 hours. That story spells instant input and review, possibly within hours. He's an inpatient. He can be reviewed within hours. Now, if I had the full lecture, I'd tell you a story about a 90-year-old man who died at a London teaching hospital 3 months after admission, most unusual for someone to be in a London teaching hospital for 3 months, but he still was in pain. Now, the doctors did everything they should, but they were always one step behind. So here again, speed, as we say in idiomatic English, speed is of the essence. And I've just had a friend die, my own age, and, you know, it makes me weep to think about the delays. I mean, 30 years ago, it was easier. I could phone up a radiotherapist and say, could you see this man at the end of your clinic? And the patient would go up straight from my clinic to his clinic. Now, it takes about 2 weeks, and then an MRI is planned, and that takes another 2 weeks. We seem to have lost something of the sense of urgency for palliative care in Britain, and I'm afraid that this one-step-behind syndrome may be there to haunt us unless we can work with our oncology colleagues to shortcut for palliative care patients. Now, I mean, any fool could be an oncologist, can't they? It takes someone very brave and compassionate to be in palliative care, because not only is, well, the demands are great because you're a psycho-physician, you're not just keeping to the physical, but it is more demanding and time-consuming than oncology or most other specialties. So how do you make the time? Did you see this paper in the Journal of Palliative Medicine, which came out a few months ago? And this was part of a trial looking at early palliative care intervention in non-small cell lung cancer. And this is a preliminary report, and they just reported on how long that initial palliative care consultation took. Now, it's within a sort of trial, so it's a bit nice, you know, it doesn't reflect totally everyday reality, but the median time, as you can see, is 55 minutes. Have you got 55 minutes for every new patient? This is the initial consultation. I've come up from Vellore. they manage half an hour. And they delegate to trained volunteers some of the tasks which I think these doctors were including, like the basic demographics, like a drug inventory, a medication inventory, and one or two things like that. But I think if you take what they are doing at the law as a benchmark, then you certainly need 30 to 35 minutes to do any sort of a decent initial palliative care valuation. Okay, so if you haven't got that time, but even if you have, you've got to focus. There are so many potential problems, 10, 20 symptoms if you went through a formal inventory. So you have to have a way of cutting through to the most essential, the most important, the most urgent symptoms and problems for that particular patient at this particular time. So these are the sorts of questions you use. You use whichever comes most comfortable to you in order to get to the nub of the situation. Okay, now Peter Maguire was a great teacher of communication skills in the United Kingdom, and he taped people, doctors, talking with patients. And he said if you start with the physical as a doctor, it's almost impossible to move on to the psychosocial. So if palliative care is about being a psychophysician, I've got to remember that. And that's why you have this open question for the patient to set the agenda, most important. And then, because you want the patient to say what concerns them most, at the end of the consultation, please fit in a rounding off question. Okay, painstaking evaluation alongside or with explanation. What have we got here? Okay, we want to know the impact of the symptom on the patient. A few short examples. Here is someone, well, you're asking about breathlessness. They've probably got lung cancer or something like that. And what is your breathing like? Now, they may say, because they've been sitting down for 10 minutes, they may say, oh, no problem at all. So you always ask a second question. And how is your breathing when you get up and start walking around? Oh, well, it gets very difficult, doctor. And then, you know, if they say no problem, that's the end. You go on to the next thing you want to know about. But if they're saying there's something problematic, then you dig deeper. This is for the UK audience. I don't know how you'd put this in Indian, one of your 26 languages. Can you get to the toilet without having to stop to regain your breath? Or no, I have to sit down every 5 or 6 paces. Does that frighten you? Have you ever said to a patient, does that frighten you? Or is that a bit scary because, you know, you might get off the well-tried physical path? Does the breathing ever get so bad that you think you're going to die there and then? And the patient nods. That sounds terrifying. Now, what you've discovered in a few seconds is that the patient has sufficiently severe breathlessness on exertion to have what we call respiratory panic attacks. And the first treatment of respiratory panic attacks is, in fact, to explain to the patients what's going on. And I've cut out the next 3 slides, well, that's tough because we only have 30 minutes. So with insomnia, because we're a psychophysician, we're not just going to give someone a tablet to get them to sleep at night. Look at the bottom line. Is it because your sleeplessness, is it because you have lots of thoughts rushing around your head and your mind cannot relax? Because if the answer is yes, don't give a night sedative. Maybe a night sedative is never appropriate. If you know what the reason is, pain or something else, then you address that. Oh yes, a night sedative is often useful, or was in my patient population. But if they say, oh, it's things rushing around in my head, then can you tell me, you know, what sort of things do you find rushing around in the middle of the night when it's dark and everyone else is asleep and you're tossing and turning in your bed. So dangerous because you're getting off the physical and onto the psychosocial. Okay, look at the bottom line here. Informed imagination before more investigation. Doctors diagnose predominantly on probability and pattern recognition, and that's true in palliative care. I'll press straight on. Management, don't forget it's not just drugs. Correct the correctable, there's a lot to do in some of our palliative care patients, even though we can't cure the cancer. Don't forget the non-drug treatment, and then of course the mainstay for many of our patients is symptomatic drug treatment, and that requires skilled prescribing. I've come to the conclusion that doctors as a body, collectively, doctors are clueless when it comes to prescribing drugs. You have to have what I call a sixth sense for therapeutics. I hope, well, maybe it goes with compassion. Maybe it goes with experience. But you take the average non-palliative care doctor, they generally are clueless when it comes to prescribing drugs and titrating carefully and monitoring for side effects and simplifying so that it's not so complicated that the patient has 100 tablets twice a day. So, skilled prescribing is crucially important. Now this, of course, we all know, it's what the WHO began to preach in 1981 and since, and that's the basis of our teaching, both at pre-qualification and postgraduate levels. And this is where I come in to indicate that I'm a salesman, that here's a book which I co-edited with Andrew Wilcock, my younger colleague in Nottingham in the middle of England. And if you want to have a training program and you want to have a good sound base for the drugs we commonly use, then this is what you should be getting hold of. Unfortunately, because it costs money, we can no longer allow free access to the online version. But now, okay. Now, if you go to that formulary, PCF for short, you'll find that under the strong opioids, it has morphine, hydromorphone, oxycodone. You haven't got half of those. The important thing is to use what you have well. Use what you have well. Now this picture is a bit of a cheat. It's a real picture, but it's not a picture of the patient in question. So I meet her on a ward round in northwest India. And there she is, lying there miserable in pain. But she has a box by her bed in which she has proxifon and buprenorphine. And I don't know when she took them. Maybe, I don't think she ever took the buprenorphine, but she took a couple of proxifon once or twice a day. But they really didn't do any work. So I explained to the nurses that I wanted her to have 2 tablets of proxifon 4 times a day and indicated the rough times I wanted them. And because she had bad nights, just add in 2 buprenorphine tablets, 2 buprenorphine tablets, 2 buprenorphine tablets sublingually at bedtime. But I also talked to the nurses about some other things they might do. So the next day, she had slept well. She was alert, relaxed, pain-free, sitting up rather than lying down. It just shows that your patients often have what they need for their pain, but they need someone with imagination and determination to help them use it and get the relief they deserve. Okay, think before you ink. That's Dr. Maliga from Chennai. Thank you for that. And remember, prescribe generic products. These are only relative costs, but if you use something like lactulose, it's not only a second-rate laxative for opioid-induced constipation, it's very expensive. Go for something which is much cheaper and makes more sense, like bisacodyl. I was told down in Vellore that if you prescribed patented zoledronic acid, you paid that much, but if you got generic zoledronic acid, you paid a much lower sum. You've got to be aware of pharmacoeconomics, and I'm sure you are. Attention to detail. Okay, don't make unwarranted assumptions. To assume is to make an ass of you and me. Attention to detail. Why? Why is this patient with breast cancer vomiting? There's nothing wrong with her alimentary tract. Why is she vomiting? You have to think it through, because there could be 3 or 4 different reasons, and they require, certainly in our experience, they're comfortable from her cancer. It was either abdominal or back pain or both. In the day, she was perfectly comfortable, 100%. But then at night, she woke up in agony, so much so that she feared to go to bed and delayed going to bed. And she told me that she was taking paracetamol every 4 hours. But when I asked her, attention to detail, do you see what was happening? There was a 12-hour gap at night. And all I did for this woman was I didn't alter the dose, I just retimed the medication so it was around the clock. Of course, it wouldn't be exactly every 6 hours, but I retimed it, and she no longer had that agonizing pain at night. She was happy to go to bed at night. This is what I mean by attention to detail. Now, you have a similar problem in this country, and I've called it the overnight trap, because patients on many wards, the drug rounds, they're 9 o'clock in the morning, and the last one is 9 o'clock at night. So, unless you make special provision or have slow-release preparations, you've got a 12-hour gap. And at home, many families are reluctant to give the patient their first dose in the day before breakfast. And in many families where there's an ill patient, breakfast isn't until 10 a.m. or thereabouts. So beware the overnight 12-hour gap. Okay, you've obviously got to learn the rules of prescribing, you've got to learn when to break the rules, and we've got to be patient-centered. Palliative care is a partnership between experts. Oh, I've said all this in, one way or another. Let's go on, because time is running out. I've got some final thoughts. What is your focus as a doctor? Physical symptoms or whole person? Please, please, in palliative care, be a whole person psychophysician. Remember this quote by a patient from Kenya: cancer is isolating, and what we're trying to do in palliative care is to reach over the wall of separation and lean down and grasp the hand of our sister and brother who's dying and lift them up and draw them back into the world we all inhabit. And another patient: doctors never have time to talk. I think communication is an ongoing challenge. Even if you've been in palliative care 5 years, 10 years, 15 years, 20 years, good communication is an ongoing challenge. What is your expectation? Some of you look young. I think you probably are young. Are you going to be in palliative care for the next 30 years? Do you think you're in for an easy ride? No. You'll find that it's a constant challenge, okay? Palliative care never gets easier. If anything, it gets harder, because people refer more and more difficult cases to you, as what you've taught them takes care of the less difficult situations. And remember this, young folk, it's not always possible to relieve symptoms completely, but we're hoping that with the patient, or helping the patient, we can help the patient move from being overwhelmed by a symptom to exercising some sort of mastery over it. Now, I think this is the penultimate slide, and thank you for not turning off the microphone. This is a quote from Pallium Indian newsletter 3 years ago. We have to go beyond competence, and this takes me back to where I started. We should not permit the growth and routinization of palliative care to take away its soul. It'll be a sad, sad day if in the process of palliative care reaching everyone who needs it in India, palliative care comes to be delivered by specialists with an MD in palliative care, just with the brain, and the eyes of the heart do not open anymore. Yes, particularly the young folk, take this down and keep it. on a plaque on the wall. So back to where I began, thought for the day. The anger in compassion is a catalyst for change. Please be angry. Please be angry. Well, thank you for listening. I've appreciated your attention. Thank you. Thank you. Thank you. Okay.
May I request Robert to kindly sit down on the chair in the middle? Yes. You're being punished for a lousy lecture. Please sit down. And can we have the that thing off? The projector off, please. The middle one. Yeah. Yes, that's great. Ladies and gentlemen, to talk about Dr. Robert Twycross to a palliative care conference is like, in a way, carrying coal to Newcastle. When you think of cricket, at least the older generation of people, will say Don Bradman. Similarly, when you talk about teaching in palliative care, and that too in India, but certainly all over the world, then the only name that will always come first is Robert Twycross. It's very difficult to adequately thank somebody who has been part of your journey in palliative care, and that applies to me too. So we felt that we have to sort of at least make a very weak, inadequate, incomplete effort to give Robert a token of our respect. And so we felt that we would like to honor him with a special plaque. And I would like to read that plaque, and then I will request Arundhati Chakraborty, the secretary of this wonderful conference, to drape him with a local shawl, and then we will give him this plaque that we have made specially for him. I read: Indian Association of Palliative Care, Plaque of Honor presented to Dr. Robert Twycross, respected scholar, a brilliant teacher and gifted author. With heartfelt gratitude and admiration for his colossal contribution to the growth of palliative care in India and for mentoring and inspiring a legion of students for over 2 decades. We salute his passion, zeal, dedication and devotion. Presented at the 19th International Conference of the IAPC, Kolkata, 10th February 2012. Ladies and gentlemen, Robert Twycross.
I really am overwhelmed. I am overwhelmed, and I'm happy to be overwhelmed, because in palliative care one has to get in touch with one's emotions. I was smiling as you read this out, because you left out one word. There should have been something about anger in it. But it's wonderful to be here, and thank you so much from the bottom of my heart. Thank you.